Welcome to Psych Incubator's Eminent Psychotherapists Revealed. We are pleased to feature Dr. David Mintz, who is the Director of Psychiatric Education and Associate Director of Training at the Austin Riggs Center in Stockbridge, Massachusetts, a psychoanalytic hospital specializing in the treatment of patients who are complex, comorbid, and treatment refractory. To address the treatment needs of these patients, Dr. Mintz and colleagues developed a psychodynamically informed, patient-centered model for addressing psychological and interpersonal interferences with the patient's healthy use of pharmacotherapy. His book, Psychodynamic Psychopharmacology, Caring for the Treatment-Resistant Patient, and dozens of other publications, explores these principles. Dr. Mintz is also the recent past leader of the Psychotherapy Caucus of the American Psychiatric Association, former trustee of the American Academy of Psychodynamic Psychiatry and Psychoanalysis, a member of the Medical Student Education Committee of the APA, and on the editorial boards of Psychodynamic Psychiatry and the American Journal of Psychotherapy. Dr. Mintz, thank you so much for joining us tonight.
You're very welcome.
Thank you, Dr. Mintz, so much for being here. We really appreciate it. And so I want to start off by asking, tell me what really got you interested in psychodynamics and pharmacotherapy?
Yeah. So maybe it starts to go back to when I started medical school. So 1989, or 1990, about a half year after I started medical school, the then President George H.W. Bush declared the 90s to be the decade of the brain. And for those of you that are old enough, this was a time that were massive shifts in the way that we conceptualized and treated mental illness, and a shift, in a certain way, a shift from what I had learned as a biopsychosocial model to what former American Psychiatric Association President Stephen Sharfstein called the bio model. And
a lot of bio.
Yeah. And so I was training, in this environment, but I had gone to medical school because I was interested in people and had already an interest in psychoanalysis. When I ended up at Riggs, the Austin Riggs Center, for my fellowship about 6 years after that, I was having this complicated experience where, I had one foot in psychiatry, which was going one direction, and another foot in psychoanalysis, which was going in a totally different direction. And one reason I got interested was this was my effort to reconcile these pieces of myself that felt like they were being totally torn apart. I think the other reason I got interested was that just the patients, taught me the necessity of this. And in fact, I think of one patient in particular, was somebody who had failed or been failed by many antidepressant and other medication trials, was extremely chemically sensitive to almost everything except for nutraceuticals. And I was and I knew she was very sensitive, and I'm a beginning fellow trying to figure out how to medicate this person effectively. And so I knew I had to dodge something, her sensitivity to side effects. So I started at an eighth of a normal starting dose of bupropion.
A microdose.
A microdose.
Mm-hmm.
So 15 milligrams. When you would normally start at 150 or maybe 75 for a sensitive person.
Yep. Yep.
And perhaps as one might expect, what she presented me with was terrible side effects, headaches, body, all sorts of things. And, we had to stop it right away. And then I did not know what to do. Mm-hmm. I reached out to Don Klein, who was one of the psychopharmacology gurus in New York at the time, smart guy. He was, and he was very clever, and he got that there was something psychological here. So he proposed that I prescribe her placebo. The patient would know it would be a placebo. What she wouldn't know is when it became active drug. So we try to sneak it in under her defenses. And this would be agreed upon. As clever as we were, the patient was much cleverer because suddenly she developed an allergy to the methylcellulose in the capsule. So So
Did she
it was-
know when she was starting? She didn't know when she was starting the actual medication.
no, well, she never got to it.
She never got to it.
Just the methylcellulose, the
The-
binding agent that made up the capsule in the placebo. She was allergic to that, and and again, maybe a hallmark of a defense that she knew in this sugar pill what she was allergic to, and so we had to stop it. And so so I was treating patients like this, who taught me, like, there is the only way you're going to be able to really help this person with pharmacotherapy is to be able to address the psychology that is interfering with that patient's healthy use of medications.
So can you give us a summary of the psychology? Like when you say the psychology, what are you referring to?
It's interesting that I think there's a pull for not just for psychiatrists, but psychologists or therapists as well, to think of medications as biological agents. And of course they are, but if you look at the research, medications in many cases are at least as symbolically active as they are biologically active.
Mm-hmm.
And even that draws a false distinction, because those symbolic actions, the symbolic activity, is producing real changes in the biochemistry of patients who are taking these things. So, for example, I can just share a couple of studies that maybe put an exclamation point on this for me. There was a study, the Treatment of Depression Collaborative Research Project, which before STAR-D was the largest NIMH-funded multi-center placebo-controlled trial that had been done. And they were looking at what's the best treatment for depression. Is it psychodynamic therapy? Is it cognitive behavioral therapy? Is it pharmacotherapy? And what they found was they're basically all equivalent in terms of effectiveness, with perhaps the combination of psychotherapy and medications being a little bit more effective.
For the more severely depressed patients, I thought it was that the medication had a better effect for the more severely and moderately to severely depressed patients.
That may be. That's I have a different study in my mind that's saying that, but maybe that was found. But the main point, the real point I wanted to get at was, a decade and a half later, Krupnik, Sotsky et al. Did a secondary analysis looking at that study through the lens of the Alliance. And it turned out that as a patient, if you got the active drug and you had a good alliance with your doctor, you had the greatest reductions in depression. If you had a poor alliance, you got the placebo, you had the least. But in the two other cells, you were better off actually having a good alliance with your prescriber and getting placebo than you were having a poor alliance with your doctor and getting the active antidepressant.
Yeah, and I think that's supported in the psychotherapy research that alliance contributes a large portion of the variance.
Yes. Yeah, and coming at it from another, there's actually just a study that came out in the last few months looking at placebo effects in psychiatry across conditions, and the effect size of the placebo effect size with antidepressants was something like 1.5. So, which is a substantial effect size. The actual effect size of the antidepressant, the medication, somewhere between 0.3 and 0.35. And this was found. This was effect sizes of similar effect sizes, 1.2 for anxiety, all the way down to like 0.5 for antipsychotics for people with psychotic disorders. And this is real stuff. Like, you can look into the brains of people who have been given a placebo and have a placebo response, like with antidepressants. And the brains look very similar. There are some differences at the brainstem level, but on the upper brain, the changes are very similar. So these substances that we're prescribing I guess the take home are at least as symbolically active as they are biologically active, which means really not as both as psychiatrists and as psychotherapists working with people on medications, we really need to be attending to the meanings that these medications hold for people.
Yes.
Right. Well, and the other thing that's interesting to me is I would like to know how that third party fits in there, not just the prescriber, but if the patient is also has a therapist, a psychotherapist working with them, does the effects change any? What do you see any difference with that, and how does that impact on their response to the medication, if any?
Well, I don't know that has been researched, the actual teamwork like that. It would be a great study to do. What I can say is that, I think that what I was just talking about, this kind of mind-body split, psychiatrists are not the only ones that fall into that, right?
Right.
And I think actually for a fair number of people I treat, there's some kind of dynamic like that, and we can easily get into this place, for example, where there's something going on around the meaning of medications, but the therapist feels like, well, I don't want to dig around there too much, right? Because I don't want to be stepping on the toes of the psychiatrist. Meanwhile, the psychiatrist is in the same place of thinking, I'm not going to be interpreting the patient's, pathological use of these medications because I don't want to step on the toes of the therapist. And this whole hugely important part of the patient's life falls into the gap between the disciplines.
Right.
So I would add another component to the alliance, and this is what I've experienced over the decades I've been doing this work, is that the alliance between the prescriber and the psychotherapist is an alliance we've never really looked at. Like, what is the relationship? And often there is no relationship, because everyone's so busy, you can't even get in touch with one another. And I think that is another powerful part of how people receive the entirety of the treatment.
Yes.
Is there, if they have a separate psychopharmacotherapist and a separate psychotherapist, are they collaborating? They don't have to always agree, but are they collaborating, and are they triangulating? And to me, that's probably one of the most important areas that we have to work on to advance and get better outcomes in what we do.
Yeah.
Right.
And I think it's easier to end up at odds. Just in terms of, there's non-collaboration, and there are ways that these treatments can be really at odds. Like you could imagine, the situation where the therapist feels like, oh my God, how's my patient supposed to do therapy? They're so bombed out of their mind, and meanwhile, and the psychiatrist is like, oh, every time I get this patient calmed down, that therapist riles them up again.
Yes. Yeah.
In
that case, the therapist and the prescriber aren't necessarily talking.
Yeah, they are not talking.
The patients triangulate it in an unfortunate way in that case, to me.
Yeah, and then patients can also do things, of course, to deepen that as their internal world is projected in the outer world. I can say something about what we've done at Riggs to try to address this, and I think people who are working in teams or who have more stable relationships with their prescribers can do this, and some of it has to do with the way you conceptualize as a psychiatrist the task of medications. Because I will tell patients in that first session, I am not prescribing to get rid of your symptoms. I might do that, but that's not why I'm prescribing. I am prescribing to put you in the best place possible to do this treatment. So I'm prescribing in the sense of a developmental model, right? Where medications are serving the patient's development and not necessarily, directly or at least the focus. We are addressing symptoms, but the focus is on what do I need to do to help the patient grow. And one of the things that happens when I do that, when I basically put the medications, make them almost subservient to the patient's therapy, right? I will say to the patient, the patient has a lot of anxiety. They want a bunch of Klonopin, but of course, I say, well, of course that may take care of your anxiety, but you're not going to remember a thing about what you talked about in your psychotherapy, with those, 6 milligrams of Klonopin in your system. So we're not doing that. We are doing whatever we need to do to help you learn and grow. And then when I've done that, the therapist is in a very different position in relation to medications, because if the patient is mucking around with their medications, the therapist is positioned to experience that in the transference, right? Or to be able to say, look, those medications are here to help us. Why are you not taking them? Yeah. And so so we work at a particular kind of integration where the medications serve the psychotherapy, and then the interpretation of the patient's use of medication serves the pharmacotherapy. And of course, that doesn't.
It reminds me of what my colleague John Santapietro often says to the patients we're working with. He's got this great metaphor. He says not to every patient, but often he'll say, so that the medication is like if you broke your leg and the doctor puts a cast on your leg. The cast isn't healing your broken bones. What it's doing is it's holding it stable so that your natural healing processes can take place. And the medication that I'm prescribing is really so you can tolerate the pain and the growth of the therapeutic process. It's not fixing it. It's holding it so you can do the work.
Absolutely. And I share a very similar, that's.
What's your metaphor?
Well, patients will say, we'll worry about using medication as a crutch.
Yes.
And I will say, this is exactly what we want. Yes. Because the whole point of a crutch is to carry some of the weight for a little bit while you heal.
Yes.
And if all goes well, you'll be throwing away the crutches at some point.
That's another good one.
Right. I like that. But I think that the other thing that's interesting is how do you weaning that person off that crutch? It's like, at what point do you say, okay, we can wean off the crutch when you're strong enough that you can handle that? Yeah.
And I think it makes it easier. Like if you're prescribing in a narrowly biomedical framework, that does something to the patient. In terms, even just, again, to quote some research, there's an interesting study done by Kemp-Lickel and Deacon about 15 years ago now, where they took college students with a history of depression. And they enrolled them in a study to determine if the depression was a psychological depression or a biological depression, genetically determined depression. So some researcher comes in a white coat, does a cheek swab, disappears for 15 minutes, comes back and tells them the results of the study, whether it's a psychological bio. Of course, we don't have that test. It was a sham condition. And then they assessed a number of things, including the patient's prognostic optimism or pessimism. And the patients who were told they had a biological depression had much higher levels of prognostic pessimism, which we know is directly linked to outcome. And patients who were told they had a biological depression also had lower levels of lower mood regulation expectancies and lower sense of self-efficacy, which again, we know is connected to treatment outcome. So when you prescribe in a more of a developmental framework, I think it becomes much easier to have those discussions with the patient about we're aiming at actually, in many cases, getting you to the place where this will become, either we'll be lowering it or maybe it will become superfluous. It's harder, I think, to do that when the idea is there's like a biological or genetic problem.
So how do you, during the biological, the decade of the brain, the biological psychiatry, and still some now, maybe not as much, but I'm interested in what your take on this. I would often hear my patients say after they met with their psychopharmacotherapist, or if they were treated in the past, that my pharmacotherapist said that I have a brain disorder, and then I'm going to need this chemical will mediate that. Just like if you're a diabetic, you're going to need to be on this for the rest of your life, and if you stop taking it, it's going to get worse because of kindling and all that stuff. And so a lot of people came in thinking, I've got a brain disorder, and with this chemical, I can actually fix it. Is that still like a bias in your
Yeah, I mean,
experience?
to a certain, I mean, like you said, I think it is shifting to some extent, that it's, at least the reductionist part of that, the maybe the pharmacomania, the excitement about medications. And I think in some ways we owe some of that to evidence-based practice. Because as we've gotten more and more focused on evidence-based practice, first that was used to kind of pummel psychotherapy, and particularly psychodynamic psychotherapy. But psychodynamic psychotherapy now has a pretty substantial evidence base. But the other thing that happened is we realized our medications kind of suck. That they're helpful, but they are seldom as helpful as we want
The
them to be.
promise of the decade of the brain has not.
Yeah.
Not lived up
So
to.
so I see a shift in psychiatry towards a much more integrative position,
Good.
where there is, well, there's motivational interviewing coming in, there's collaborative care models, which recognize you need a lot of people involved working together, psychodynamic psychopharmacology. So I think these are all part of a recognition that a reductionist or dualist approach doesn't really serve our patients. Now, I don't want to give the impression that I don't. There are patients, somebody who's had a psychotic mania and wanted to jump off a building because they thought they could fly. I'm saying to that patient, I think you should probably be on this medication for the rest of your life. But there are lots of other patients who have milder forms of illness that might be able to be managed either by getting a handle on their mood regulation, much better social rhythms, all sorts of other things. And I think that that's a focus, is to try to empower from the position of psychodynamic psychopharmacology. It really is an effort to mobilize the patient's authority and empower them to be more of an agent in their lives. And I think you're describing a situation also where, probably with good intentions, these doctors were talking up the potency of medications, because there is research that shows that you can increase the placebo effect if you're
Or
really
nocebo
effect, which I'm sure we'll talk about. But I think that backfires, because for a lot of people, like for a treatment naive patient, that may not be a bad strategy. This is a really good medication. But by the time somebody has failed a medication 2, 3, 4, 5 times, there's a study by Preeb that really shows patients then do not like it when we're so optimistic, because they feel like we're gaslighting them. It doesn't match their experience. And I think the risk is that we also disempower patients, because the worst, like we all treat patients who are like, okay, doctor, fix me.
Yeah.
All they have to do is wait to be healed. And it's a terrible place
I met with a patient last week who said, working with a pharmacotherapist who administered a checklist to this person, and by the end of the session, where nothing was asked other than reviewing the checklist, went out with a bag of pharmaceuticals, and from there on, it was one after another, and none of which worked. The next best thing, and no one ever even did a history of trauma, like what's your trauma history, which was substantial and undiagnosed and unrecognized. And I worry about so many people now getting prescription privileges who are not well trained in psychodynamics and psychotherapeutics and many of the other topics that are so critical to the work. Like just throwing medication at people seems dangerous.
Yeah, and there is a I think you're describing what is, maybe could be described as a kind of a lost generation. There's a paper by Eric Blake called "Psychiatry's Lost Generation." Of this generation, I think the pendulum reached its biomedical apex at the end of 2009. And we've been moving slowly, right at the edge, it starts swinging slowly. But I think we've been, but the generation between 1990 and into the 20-year period, really, there were a lot of psychiatrists who were not who are getting all this messaging about it's all about medication. So I worry about that too. I think it's shifting, and I know my book is being taught in a lot of residencies now, and it's maybe the most gratifying thing about the book is the people that are most excited by the book are the residents, because they're close enough to the idealism that brought them into psychiatry, and they're in these systems that are like chipping away at that with the demands from their corporate overlords for efficiency.
Prescribe every 10 minutes.
Yeah.
And so, and what I hear from a lot of them is that that's the thing that helps them hold on to, that psychological framework that was what interested them in psychiatry in the first place.
And I think that to me, you're just getting at touching a point, because one of the concerns is that you're not reinforced to have that, that therapeutic alliance with the patient. You're not financially reinforced for doing that, just get them in and get them out. And we know that the relationship is an important aspect in the way people respond to the medications. It's like, how do we get the carriers really understand that and to follow suit and to work with our colleagues in doing that we know is the best for the patient?
That's a great question.
Mm-hmm.
I will say, I think part of the problem, it has to do with, like you said, how busy and stressed everybody is and the demands for efficiency that we're under. I have this experience when I talk about psychodynamic psychopharmacology at like a state annual review of psychopharmacology in like Alabama or something, and I'm there with all these other biological psychiatrists talking about the importance of the alliance and empathy and the meaning of medications. And there's, 100, 150 psychiatrists there. And 95% of them are sitting there thinking, I believe this.
Mm-hmm.
And they all think they're the only one.
Oh, wow.
Wow.
And then a group process gets going where they start to realize that basically everybody in the room thinks the relationship is super important, the meaning of medications to the patient. But we're in systems which are attacking our ability to think together about this. And I keep feeling, and it's one of the reasons why I'm doing this podcast and do things like this, because I feel like if we can get enough of a critical mass of psychiatrists understanding, we almost all feel this way. Mm-hmm. And there's good data to back it up, that we may be in a better position to start pushing back against, the forces of capitalism or, corporate medicine.
Capitalism, right.
That are they're trying to strip away the fat, and for the corporate overlords, the fat is
going to them,
thinking, so and we're not there yet, but hopefully we'll get a critical mass and enough people will have the research, the evidence bases in their heads that we'll just be in a better place to say, this, you probably know this, like 40% of psychiatrists operate outside the insurance system. And I don't think it's because of the pay. I think it's because the pressures they're under to give care that they know is suboptimal.
Mm-hmm. Oh, yeah.
Mm-hmm.
Yeah. I have a question about, I have a lot of questions, but I'm going to start with one, about when you're meeting with a patient, how might you talk to them about the meaning of a medication? Like, what might you say to them? I'm really curious about that, and like frame it to them.
Yeah, so maybe I'll give you, because I think it's important to do this from the first session. I think it's much harder to wait until there's problems and then shift gears and start thinking about the meaning of medications. So, so some of that was what I show the patient, and then some of what I show the patient is I start with a developmental focus. It's like not what brought you here as much as what are you hoping to get out of this, and where are you trying to get in your life, and then secondarily, and how are the symptoms getting in the way of that? So it's framed around them as a person. It's a person-centered developmental focus. And the way that will often go is they would start to tell me about some of their troubles, And at least for the people I treat at Riggs, many of whom have, as most of your patients probably do, like some significant early adversity. So at some point I'm asking, like, well, how far back does this go? And now suddenly they're telling me about like the anxiety they already had at the age of 5 or 6, and whether that's trauma or, an overbearing father or whatever that is. And then at some point, and then in that context, I ask, they start to tell me about that anxiety. And then it's like, well, do you have any hypotheses about why you started to struggle at that age? And now they're telling you about the psychosocial environment that was like the breeding ground for their trouble.
Mm-hmm.
And then once they've told me maybe about their authoritarian father or whatever, then I will ask, well, how does that color how you relate to authority figures and caregivers? And boom, now they're telling me about the problems we're about to have, right? And then I'm saying to them, so we should pay attention to that because chances are there's a good chance that'll come alive in our relationship. And one of the things I'm doing is I'm starting like a frontal lobe to frontal lobe conversation with the patient because, 4 months down the road when their limbic system kicks in and is telling them that I'm exactly like their father, there's a better chance of restoring that frontal lobe conversation and saying, oh, remember we talked about this in that first session. So there's a fair amount of that. There's a number of questions about, I will ask, well, what's it like for you to take medications? And right there, the patients will, may tell you about the whole reason that they stop them every time, they start to work or, and what's it been like for you working with doctors? And they will usually, much of the time, either like their doctors are godlike and, that's the problem is that they give all their power to the doctor, or more often, the doctors were narcissistically preoccupied, brusque, didn't care, something like that. And then we can talk about the relationship. And at some point I'll say, one of the reasons I'm asking about all this, and I will do some psychoeducation, not just about the medications, but about the meaning of medication. So usually I'll talk about the placebo effect and how powerful it is, accounting, as we said, for like with antidepressants, at least 3/4 of the effectiveness of antidepressants and half of antipsychotics. If the patient has had a lot of side effects, then we'll start talking a little bit about the nocebo effect.
Mm-hmm.
And that psychoeducation will probably always, if not almost always, then talk about the alliance and how the alliance actually is probably a bigger determinant of medication outcome than the medications themselves. And I'll say to that patient, one of the implications of this is not only does it mean that I want you to tell me if I'm doing something you don't like, but I need you to tell me. Because if that's happening and we're not talking about it, chances are the medications are not working as well as they might. And that's my goal.
Mm-hmm.
And so, starting a conversation from the first day that then paves a path for when there are problems.
Mm-hmm.
Patient has a side effect. If we've never talked about it, and then suddenly you're saying, well, maybe this is a nocebo response, the patient is like, oh, you're blaming me for the side effect you just gave me? But if you've cultivated a much more complicated and nuanced understanding of what's happening in that pharmacotherapy process, puts you in a much better place to start asking questions. The patient, says, I'm depressed, and you can ask, well, how do you know that's depression? What tells you that's depression as opposed to sadness or anger? What was happening when you started to feel more depressed? And so, may save you from having to start a medication because the patient is really just ticked off at somebody and it's all getting pointed inward.
Okay, so now it seems to me you're also you're intimating that you have enough time to ask these questions. How long are your pharmacotherapy sessions?
Well, okay, so yeah,
I was actually thinking the exact same thing.
So this is a good question because I think I don't think we have to do this in hour-long chunks throughout a patient's treatment. I think a half hour 25 minutes, 20 minutes, every month, a couple of months is fine. But I do think we really need, I need 2 hours up front.
From the first session, 2 hours.
No, two 1 hour sessions, like over across a week,
Okay.
because because day one, I want to know who the patient is.
You're establishing rapport.
Yes,
getting
we're
this-
putting the relationship on the right footing
Mhm.
for medications to work.
Wow.
Right.
Day two, trying to figure out what the patient is and honing in on what are the right medications. So day one, I'm trying to figure out how to prescribe. Day two, I'm trying to figure out what to prescribe. And we don't get that, most psychiatrists don't get, if you have a private practice, you can do that.
Mhm.
And the systems that most of us are working in, it is so, from my perspective, penny wise and pound foolish.
Mhm.
Well,
You save a bunch of money by cramming that into an hour or a half hour, but that patient doesn't take their medications, doesn't get better, ends up in the hospital, costs, now $10,000
Way more.
in the hospital.
Mhm.
Right.
And so I think, and again, there's not great research to back this up. We know, well, there's some studies that really show how focus on psychological issues cuts down on psychiatric intensive focus cuts that down on long-term psychiatric costs. But the specific thing I'm talking about has not been researched. But if you take seriously all the evidence that speaks to the power of the media medications, the doctor-patient alliance, patients' readiness to change, all these psychological factors. If you can get a handle on
that definitely takes time, because a lot of what I experience is, what are your symptoms?
Yeah.
Here's your diagnosis, and here's the medication, and
Oh,
buy.
yeah.
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 So, what I was thinking is, the way you laid it out is like, in the best case scenario.
Yeah.
But given the reality of the situation and the parameters in which we have to operate in, so how do we make modifications on that to still kind of get at what we need to get that best treatment outcome?
Yeah, I am trying to figure that out. My daughter's a PGY3 in psychiatry, got a half hour for all her new patients.
Right.
They got transferred, and I'm trying to help counsel her, and it's really hard. And I think in an hour intake, you can do a good chunk of this.
Yes.
But when people are under that kind of pressure to get to know somebody and figure out what to prescribe in a half hour. I actually don't know what to say about that. I think it is. Yeah. It's why, it's one of the reasons all of our patients are not getting better is that kind of thing. Now, I think as I said, I think it can be done in an hour. I think it can be done, like if there's an issue around the patient's readiness to change, I'm not doing that work. I'm identifying it. I'm speaking to the patient about it. But that's a situation where I'm then getting on the phone and saying to the therapist, my own hypotheses about the patient's ambivalence about getting better or whatever that is, and how that might be contributing to the treatment refractoriness. So it's not like I'm taking all that work on myself, but I'm, again, as we talked about earlier, trying to use the team in a way, and to work collaboratively in a way that amplifies that.
So how do you deal with countertransference issues within yourself and also within the psychotherapist? I mean, what I mean by that specifically is, like, if you're prescribing medication to someone, it doesn't work, you try another one, it doesn't work, you try another one. Sometimes I get the sense that hostility can build up toward the patient, that you're a bad patient, you're not responding to treatment. And sometimes I sense frustration and irritation and dismissiveness in both the therapist and the pharmacotherapist. Can you say a little bit about the countertransference domain of the work?
Okay, yeah. Well, I think there's two things I want to say about that. One, right, we work in close quarters. with intense pain. And, through projective processes, the patient's pain becomes our pain, their anger becomes our anger, their helplessness becomes our helplessness. And, and there's some evidence that particularly with difficult to treat patients, a lot of medication decisions are not rational. So and I get those patients at Riggs, right? They come in and they're on 3 mood stabilizers and 2 antipsychotics and, an antidepressant and something for anxiety and something for sleep. And, and probably with all those sedating medications on board, they also need a stimulant. And when I see that, and this is what I say, when I see that patient, my first thought is this patient has made some poor doctor suffer an awful lot to get a medication regimen that looks like that. So I think part of it is just being, and again, this is one of the 6 technical principles of psychodynamic psychopharmacology.
Can you summarize those now for us, actually, since we didn't get
Sure. Do you want to let me finish this answer,
Okay.
and then we'll summarize those. But that we just need to be aware that the psychotherapy encounter, as Elvin Semrad, who was the teacher of my teachers, said, psychotherapy encounter is an encounter between a big mess and an even bigger mess, right? Like the patient is not the only person who's irrational. The patient is not the only person who is an unconscious. So we just need to be mindful that we're not doing this from the position of from a great distance in a position of rationality, so that we can begin to catch that. And I think maybe the most important thing that I recommend is that psychiatrists should be doing a dynamic formulation, a brief one, 3 sentences, 5 sentences, 6 or 8 maybe if it's a complicated patient, on every patient, because we know there's evidence again that there's a study done by Trellower, who's a CBT researcher, that found that having a psychodynamic formulation preserves the clinician's empathy over time. So having a dynamic formula, there's a patient. One of the formative patients for me was somebody I treated very early on in my fellowship. A patient like this, psychotic, came in on a woman in her mid to late 40s, 20 plus year history of unremitting psychosis. Came in on a first generation antipsychotic, which was not working because she was hallucinating, she was delusional, she was disorganized. And of course I wanted to try a second generation atypical, and she was so resistant. She was sure that if she took this medication, she would get depressed and kill herself. So like a delusional kind of belief about that.
Right.
But of course, what it meant was, I would cajole and push her. Eventually she would agree. But the moment she put that pill in her mouth, her anxiety was running so wild that her psychosis was ramping up. And within days, I felt like I had to stop this because I'm actually causing more harm than good. And at some point, and I went through this several cycles, feeling more and more thwarted, more and more helpless. And at some point, I get it. Because the story with this woman is in her early 20s, probably in the prodromal phase of her illness, she gets pregnant. She has a great father's nowhere, but she has a great supportive family. She has her child. She raises her child with a lot of support from her family. She's a little bit crazy, but a loving mother. And then when her son is 5, he develops a glioblastoma and dies. Nonstop psychosis. And you can imagine what her most common hallucination is, the hallucinated voice of her son. He's always there. And among her top delusions is the idea that she can cure AIDS and various deadly diseases, and that she holds the secret for raising the dead. Okay. So like what I have to offer her is so puny compared to what her and in that, that sometimes I'm sharing formulations with patients. This is not a patient I'm sharing this formulation with. The value of that formulation was it restored me to a place of empathy. And allowed me to kind of get off her back and be supportive while she did grief work in her therapy. And like 7 months later, she was ready to accept a trial of clozapine.
Yeah.
And, so.
Well, I think what Bessel van der Kolk writes about in his Body Keeps the Score is that we don't identify or diagnose trauma, and we throw, and there's so many symptoms like that.
Right.
That's a severe trauma that that the psychosis was somewhat of a defense against the unbearable pain of
Yes, absolutely.
moving. And so you can't, it's more than a person can bear. So psychosis in that case to me is like a defense against the unbearable nature of it. The medication maybe could hold her in place till she could do the trauma work, hopefully.
Yeah.
Fascinating.
Well, actually, she did the trauma work without the medication. It was the trauma work, or it was the work around grief, or grief work, really, that let her get to a place where she could accept a helpful medication. And it was, maybe a best possible outcome, because she became much more organized, be able to develop adult friendships for the first time in her life.
Wow.
No more delusions.
Mm.
And in a maybe what was a best possible outcome, she never did lose the hallucinated voice of her son.
Interesting. Did she end up taking an antipsychotic?
Yeah, she was on clozapine.
She
She took
was
clozapine
and
she took clozapine, and those symptoms when her psychosis
but
was
not that one.
Mm-hmm.
Yeah. And
So I have a question that was put forth earlier, and I didn't get it, but the question is that the term crutch is laden with judgment. Perhaps protector or guardian might facilitate understanding and compassion for the crutch coming from internal family systems. I don't know if you have anything you want to say about that, or if that's just self-explanatory.
Well, I'm trying to reform the meaning of that. And there's something about there's something about the paradoxical nature of it that catches people.
Yeah.
And especially people that are counter dependent, like that's part of the problem with medications is just the assumption that a crutch is bad.
Yeah.
Crutches are not bad, right? That question kind of falls into that mythos that if I break my leg, I'm not going to say, well, I don't want to use a crutch. I'm going to put all my weight on my foot, right? That's not how. So, and there is, I think, something about the paradoxical, getting that paradoxical thing that does get people's attention.
Yeah. Now, and someone also commented on your Don Quixote picture in the back.
Yeah. Well, doesn't every psychiatrist have that in their office?
I don't think so.
Now, you had asked me to say something.
Can you just summarize the principles from your
for our listeners?
book?
Yeah. So the model that we developed is, so the first thing is, and this is aimed at mostly at prescribing psychiatrists, the model, but there's a lot in it for, as you've heard, for psychotherapists who are working with patients on medications. But the first is to avoid a mind-body split, which, easier said than done. To know who the patient is. I mean, therapists know who the patient is. For psychiatrists to know who the patient is, and maybe specifically some of the things I talked about. So basically, early developmental models and relational patterns that may interfere or come into the pharmacotherapy relationship. Attend to the patient's ambivalence, because patients are ambivalent almost always, and it can undercut treatment effectiveness. And any of these we can probably any of these topics we could talk about for another half hour.
Yeah.
Foster the pharmacotherapy alliance. So that's a major goal of what you're doing, is not just the right medication, but the right relationship. Attend to counter therapeutic uses of medications, which we haven't touched on that much, but ways that patients use medications defensively to get in the way of their growth, their adaptability, and in a way, there's a way that they use medications almost guarantees they're going to become a chronic patient. And then the last one that we were just talking about is attending to counter transference enactments and prescribing.
Can you say there was an article, I don't know, might have been 5 years ago, that I'm sure you knew of and read in the New Yorker about medication insufficiency, that when people come off these medications that are so powerful, especially if they do so abruptly, they can have horrific effects. And often it's, at least through the perspective of the person who wrote the article, in her work, was that was fed back to the person is this is the reason why you need to be on this for life, as opposed to you're coming off a powerful brain chemical too abruptly, and it's causing havoc.
Shocking.
Yeah. Well, if we think about that, like you're doing narrowly from a biomedical perspective, of course, one reason somebody might say is they might confuse withdrawal effects for recurrence.
Yes.
And I think that that's a risk. But I think, another piece of that you get a little bit more wiggle room to work with patients is if you've brought in also the meaning dimension, because these are patients who are experiencing harm.
Yes.
Right. And, one of the, I will have set up a patient, hopefully, to be able to ask the question about nocebo effects, the interpretation of these things, because, of course, there are big differences in, if you're predisposed to feel harmed, and now you're getting those brain zaps. Now that, even though it's harmless in a certain sense, it's not dangerous at all, but it feels dangerous and it feels intolerable, right?
Mm-hmm.
Whereas another patient, years and years ago, I was on Effexor for a period of time. I stopped it cold turkey, and I was like, oh yeah, I had brain zaps for a month. But for me, it wasn't alarming.
Okay.
And so, some of that, again, it gets back to the psychology around that, the patient's object world, their attachments, their basic object relations. And so it's really complicated. Some of which may be biological. Certainly there is, we know that there are ways that receptors are upgraded or downgraded, and if it does leave people more sensitive, probably makes sense then to taper people really slowly, but also makes sense to be thinking with the patient about the meaning of their experience of being harmed, in case that gives the patient and the doctor a little bit more wiggle room to work around that kind of thing.
Mm-hmm.
Did you have a question, Lizzie?
No, yeah.
Can you give us a little advice on one of the issues that has really been challenging in my work over the decades is how to develop and maintain a collaborative relationship between the pharmacotherapist and the psychotherapist if there's a split treatment like that.
I may not be the best person to answer that because I have it handed to me at Riggs. I'm in a system where I'm on a treatment team.
What makes it work?
Well, I think I probably already answered that. There's a way that we meet twice a week.
Okay, so that's important. You're communicating.
Well, I was going to say time would be one of the important things. That
so time is an important thing.
Yeah.
And like I said, there's the way I conceptualize the medications, it directly serves the therapy.
Yeah.
And there are places where I'll get on the phone. So we haven't talked much about this, but I think, the scenario I gave before where the patient has something going on with medications and the therapist doesn't want to talk about it, and the doctor, and the prescriber doesn't want to talk about it. I think we should both be working in that gray area. The psychiatrist should, the psychologist should, or social workers, is therapist. But when I've given an interpretation to a patient about their use of medications, maybe to say something about this, I think that's a place where I will end that interpretation with the phrase, and I think you should talk to your therapist about this. Mm-hmm. And that's a place where I will get on the phone and say, just want to let you know,
Good.
I offered this interpretation to your patient. So I'm pushing it back and pushing it into the therapy, and then hoping that the therapist will feel comfortable working in that gray space in between the disciplines as well. And then that, I don't want to, I mean, you don't want to become an auxiliary therapist for that patient.
But at Riggs, you're not siloed like we are. Like I'm in private practice, Jennifer's in private practice, Lizzie works in an inpatient setting.
Mm-hmm.
I don't know how it goes for you, Lizzie. I don't even know. Do you ever see the psychopharmacotherapist?
Oh, they're in, then they're out at another hospital. They jump around. So they like meet the patient, like, you good, you need anything? And then they leave. Zero relationship. Yeah, just the way it's.
I mean, if I was in private practice, I can say, and again, some people will be out of luck with this, but I would be inclined to work with a small number of psychologists or psychotherapists that I knew were doing good work and we could work together, because I can't keep track. I can keep track of, a dozen and a half therapists.
Yeah.
And beyond that, my brain just won't do it. And again, 20 years ago, 40 years ago, we worked that way. And now we've got such a fragmented system,
right,
that it is much harder to do that.
Well, and I always appreciate when the psychiatrist will call. I mean, even if he leaves me a text message, I'll just call and say, "Hey, this is what happened today. I'm concerned, and I think this is something that you two can address in therapy."
I think that goes a long way.
I mean, it's so appreciative. It's like, so you really want to feel that we're all part of that team, the treatment team, equally, and working with the patient, and the patient is the other part of that treatment team.
Yeah, and actually, I said at one point, I said there's not research on that, which is actually in a certain way not true, because there is research on the collaborative care model.
Yes,
where there is some of that, where there would be those kind of communications. There would be like, I'm going to hand this part off to the therapist. Unfortunately, I think in that model, sometimes, there's this, the very specific APA model says it is empowering each member of the team to work at the top of their license. But what they mean is, well, the prescriber, the psychiatrist can prescribe and nobody else can. So that's the top of the license. And I don't think that's true. Because I mean, it's true of a physician's assistant. That's the top of their license. With the psychiatrist, I mean, we get 1,000+ hours of psychotherapy training. And
we have a question, if you would, one of our viewers. I was wondering if you could speak to working with patients in the psychiatric ER and tips when thinking about starting medication psychodynamically while they're in crisis, as well as knowing likely you won't see them again.
Yeah, so I mean, there's research around this, around patients with psychotic illnesses, I think, that suggests, again, not a surprise given everything we talked about, the alliance you create with that patient, even in a brief encounter, is the thing that makes a difference between a treatment they're going to take and a treatment that they're not.
Yeah.
If you're starting there's another study. This is an inpatient setting, but I think it applies to the ER. If you're going to be prescribing, a study by Woolley at your institution at the IOL, Woolley and Goethe, and where they took patients who were hospitalized with suicidal depression, and they were started, I think it was on escitalopram. They gave them a choice. Do you want to take this medication once a day or 3 times a day? Totally meaningless, clinically meaningless choice. Just that choice increased the likelihood the patient was going to be taking that medication 4 months later, 2.5-fold.
That's fascinating.
And if the patient agreed with their diagnosis also, it increased the likelihood they were going to be taking that medication 4 months later, 7.3 times.
Wow.
So, I mean, one of the most powerful things we can do is give our patients choices. And it's so easy, because with almost all of our medications, there's like 5 medications in that class that work relatively similarly, don't have major differences in outcomes. So where we can, offer choices. And some patients will, say, I'm not the doctor, you decide. But oftentimes patients will, it makes a big difference. So that's a couple of things you can do.
Well, I think we're out of time for tonight. And thank you so much,
Thank
David,
you
for
so much.
Thank
sharing
you.
your
Appreciate
expertise.
it.
And we truly hope that you'll come back, because we could spend many more sessions learning from you and having you share your expertise with us. So thank you again. And for those who are watching, thank you for joining us. And we're going to stop the recording and hang around for a couple of minutes if you want to submit some more questions. Thank you. And
thank you too.